All right, so first of all, I would just want to thank the Montreal Heart and the Montreal Symposium Live coming to invite me. I'm very impressed, Philippe. I have to say congratulations for this format because it's highly emotional, it's very engaging, it's very fun to discuss and debate with everyone. So congratulations for such a nice 25th anniversary. So I'm going to talk about coronary assessment and link a little bit to revascularization strategy because coronary assessment could be a very large topic. Was wondering what to do, talk about QCI, visual CT, FFR, etc. But I decided to take an optic more of heart team approach and score system and decision, and I think we can discuss much more after. Okay, should I take that? All right. So here's my disclosure. So a few questions actually when we talk about the level of CAD assessment. First of all, what is a significant lesion? And we can discuss if we talk about anatomic definition, functional, ischemic definition. It's extremely important. What lesion need revascularization? It can talk about vessel size, about myocardium at risk, and ischemic burden. Then after that, what is the best mode of vascularization? I think cabbage, PCI is a two option, but also hybrid should be strongly considered. I think this is a great strategy for many complex, highly complex PCI, and I think we could discuss in this forum for sure. One thing that I want to discuss maybe for the discussion is talk about specific subset of patients that have been tagged and labeled as strategy of vascularization, cabbage or PCI, and syntax IOLO. I think that's important not to fall in the dogma of the subset, and we can discuss more. And then also for the sake of discussion, when you assess revascularization strategy, it's important to keep in mind the length of follow-up that we have, because we have 1 year, 5 years, 10 years, more than 10 years, and what is long-term for a trial could be very short-term for a patient, and that's extremely important concept. So just to put things in perspective, when we look at the evolution of CAD assessment linked to guideline of vascularization, we evolve a lot. Maybe 30 years ago, we were talking 20 years ago about diameter of 50% stenosis by angiogram is a significant lesion. Then we moved to 70%. Then we moved to FFR, ischemic assessment, to 0.75 to 0.8. And then we're going to probably see in the future FFR by CT scan. So we're moving to a different CAD assessment that is more refined and linked to prognosis. After that also, the guideline changed also. At the beginning is every lesion more than 50% involving your proximity should go to cabbage. And after that is every multi-vessel patient should be cabbage. And then after that, diabetes should be cabbage. Then we evolve to more complex disease involving complex feature of coronary disease with the syntax score. Then we move to what we can leave behind, and then we are moving to, I think should be optimal, is the functional syntax score. I think we're evolving to concepts that involve more and more the role of a heart team, which is extremely important and less only visual assessments in the CAD lab. One quick slide on angiogram is angiogram is a poor discriminator for lesion severity. We all know that is a black and white picture, is a 2D picture, and we still don't know what is the severity of this lesion by angiogram. We do IVS, look ugly. We do FFR, it's normal. So I think it's very important to keep in mind that angiogram is not the ultimate gold standard for lesion severity, and mainly because we're limited by the projection, and it's only a luminogram more than intravascular imaging. And you can see here, if you do intravascular imaging, you're going to see much more disease than you can see by angiogram. Quick words on QCA versus visual assessment. If I take 100 operators in the room and I put an angiogram, we're not going to reach a consensus of a severity of a single lesion. And this was a nice paper of 175 patients in circulation that showed that among 228 lesions that was PCI in 7 US sites, actually the mean difference between QCA and visual assessment was about 10%. But more importantly, of all the lesions considered 70% or greater by a clinician, more than 25% were measured less than 70% by QCA, and the weighted kappa of 0.27, which is terrible, was found between QC and visual assessment. And so importantly, lesion more or less than 70% was not well discriminated between operator, but also between QCA and operator. Angiography and physiology, one few words. There's a poor correlation between visual assessment and ischemic evaluation. The correlation here in this seminal study was 0.35, so very low. So it's not because you see a severe lesion by angiogram that will necessarily be severe ischemic-wise. And this is a lesson learned by FAME, actually, that if you take all the 3-vessel disease from FAME, 115 patients, and you do FFR, you're going to end up with only 14% of these patients being 3-vessel disease, and reclassify a substantial amount of these patients in one single vessel disease and to 2-vessel disease, potentially changing the treatment strategy for this patient. So extremely important to say that the dogma of the angiogram should be avoided, and we should do more physiology assessment. And that's the reason why ACC in 2011 recommend FFR assessment as a class 2A when you have intermediate lesion, between 50 and 70%. And actually the guideline, the European guideline or more in advance, recommending actually class 1A for any intermediate lesion that might cause ischemia based on clinical judgment. So extremely important concept in which we can debate if it's still applicable for both PCI and CABG, which I think it should. So now a few words on score. Actually, at the beginning, we had only the syntax score, and I think life was great, but it got complicated with many iterations of this score being merged with some clinical variable, with doing before or after, and merged with functional assessment. Few words on the syntax score. There's 11 variables. It's a very successful model, probably one of the best models to identify patients at high risk of adverse event. That being said, Jean-François highlights some limitation. There's a lot of variability between readers, and there's a strong learning curve, actually. And this is a paper that Jean-François alluded to, is when you look at the syntax score trial, 32.6% of the patient in the syntax trial, I don't know why this slide didn't show well, but underestimate the syntax score, and 62% overestimate the syntax score by site. So that's very important. 32.6% actually overestimate the syntax score compared to QCA. Very important. So there's a lot of discrepancy. The good news is we did that is we see that with appropriate training, you can reduce the variability. And this is a study we did in the core lab. We read 3 doctors, we read 30 cases, and we were at very poor kappa of 0.33. It's poor agreement. Then we sit with a core lab, we review 60 film, and we train on the website, and then we had almost a perfect agreement after that. So 2 points. If you train properly with people who know the syntax score, and 2, if you do as a team, as you alluded, Jean-François, I think you can improve the variability of the syntax score and improve is potential for a hard team. One concept that I think is important is the residual syntax score. It's not only to assess the baseline syntax score, but assess what we will leave behind with one or the other revascularization strategy. So it's really, if you do the PCI, what will you left behind? And if you do the CABG, what you're going to left behind after the revascularization. And actually, we determined for the first time that a cutoff of 8 was the gold number, the lucky number for this. And this is the concept, for example, if you have this 2-vessel disease with a syntax score of 14, above the RCA, the distal RCA, and the diagonal, and you do the PCI, you remove 8 points and you're left behind only the diagonal of this intermediate lesion of the RCA, you have a residual syntax score of 6. So, and like I said, we determined actually that the residual syntax score of 8 was the cutoff where you start to change prognostic if you left more behind. And the concept is really, you don't need to revascularize compulsively everything using a cutoff of 1.5 millimeter and 50% diameter stenosis by syntax score, but you can left some stuff behind. And it was a gradient actually of events showing that if you left more than 8 behind, you have 22% of MACE, and if you revascularize completely, actually with a residual syntax score of 0, you have less MACE. And that was also true for mortality, with the lowest rate of mortality after complete revascularization. A lot of pitfalls to that we can discuss, but that's the concept behind. that is more important. And residual disease left behind was one of the strongest predictor of mortality and MACE, and actually was stronger than the baseline syntax score. So maybe a marker of disease, but also a potential guide for strategy decision making. And this concept was pleasantly validated by Vasim Farokh in the syntax trial, with actually the same cutoff found of 8. So it seemed to be really the lucky magic number. And then we push a little bit the envelope with the concept of reasonable revascularization, and we create what we call the syntax revascularization index, which is just a proportion of syntax score that you remove. So what is the proportion of myocardium you will be at risk that you will be able to revascularize? And actually we found, and this is a complex formula which is not very complex, if you have a syntax score of 30, you remove 20, you have an index of 70%. Roughly. And we found actually that 85% was the cutoff. And again, there's a nice stratification. If you're able to remove everything, 100%, you have good outcome compared to if you remove only 50% of the burden, which is very intuitive, and is true for mortality. And like I said, the cutoff was identified of 80%. If you remove 80% of the burden, you improve prognostic and you have no difference in mortality. And I validate this concept in the syntax trial, and the two first, that death is very important. If you remove 100% of the burden, or between 70 and 100%, you have no difference in mortality. That's an important thing. After that, you increase your mortality. Of course, you can increase your MACE, your TVR, your TLR, but you don't change the crucial, the hard endpoint of mortality. So that's what we can call reasonable revascularization, because sometimes it's not possible to remove everything. Then we went to combining score, meaning that you take the syntax score and you combine variable to improve the discrimination capability and the discrimination capability of the score. So I'm not going to go through all, but this, I think, the global risk score, which combine the Euro score with the syntax score, showed actually, as you can see, compared to only the syntax score at the top and the bottom, the global risk score stratify better patient in the middle cohort, because you have patient with 32 that will benefit, that will not go bad with PCI. On the opposite, you have patient with in the around 22 that will go bad with PCI. So I think the fact to integrate other clinical variable will help you to improve the discrimination and the calibration capacity of the purely angiographic syntax score. And that was validated also in left main PCI cohort. As you can see on the left, the global risk classification has a more a gradient, more gradient than the clinical syntax score or only the anatomic-based syntax score. And this is, on the top right, is really the ideal score with combined best calibration and discrimination. And you see that the global risk score is the best one. Then the functional syntax score, which I think this is where we should talk more, is when you only consider the syntax score that give ischemia. Only lesion that give ischemia should be computed as the syntax score. And I think that was validated from FAME 1 and FAME 2. And the only pitfall is you need to do an invasive evaluation. But the good news is we have CT scan FFR coming, so we can do that automatically. And I show this slide again, but in the FFR guide syntax score, 33% of the iris classify the iris syntax score based only on the anatomy were reclassified. And the low risk patient grow from 30 to 60%, and the iris decreased from 30 to 20%. So 30% of the patient move to the lower risk category, which is extremely important, reinforcing the fact that if you do syntax score, you should only do the syntax score of lesion that you think that give ischemia. Of course, there's some caveat of the functional syntax score that does not include clinical variable, but I'm sure we're going to have functional syntax score 2 score coming soon, but that's probably the last step, hopefully. So this is the CT scan FFR, which I think is very promising. It's a hard flow technology where you can assess by CT scan A, the anatomic severity of a lesion, B, an FFR of each lesion. And also you can compute if you fix this lesion with a stent, what your FFR will be. So this is where we're moving to pre-planning, planning of a procedure with a CT scan. And this technology is still in infancy, still need a lot of validation, but it's very interesting. So one paper that I'm going to talk about is that reinforces the fact that functional revasc is more important than anatomic revasc. Is this paper in JACC that was published, I think, 2-3 weeks ago, where they took the same patient, 400 patients, and they compare, and they just only take the patient with FFR guide revasc, so complete revasc by FFR, and they show that it doesn't matter the anatomic residual syntax score that you left behind. Meaning that if you revasc all the lesion with ischemia, that's what is the goal, and it doesn't matter if you left 50% lesion in D1, D2. So extremely important concept, showing that scoring system with a purely anatomic approach are insufficient and maybe misleading. And I think that's very acceptable thought, actually. All right, the syntax score 2, the last step, the last slide. This is a great concept. It's aiming to individualize the treatment of PCI versus CABG for any level of syntax score. Trying to show, is there a syntax score of 40 that will be more suitable, more favorably treated by PCI versus CABG? Is there a syntax score of 10 that will be better by CABG? So it's an attempt, a first good attempt to prove, to individualize the treatment. And Jean-François alluded to the variable that we're showing to have an interaction. And very interestingly, but not surprisingly, diabetic patient was not a variable that showed interaction, meaning that the complexity of the anatomy is more important than the status of yes or no diabetic. And we can debate that point. I'm going to go to this, but for a same patient, what we're doing is we compute 2 scores. We compute the baseline syntax score, and then we compute the CABG syntax score 2 score, and we have a number. We compute the PCI syntax score 2, and we have a number. And then we see actually what is the associated 4-year mortality. And I think that's this will come in a website very soon, and I think that will help. But once again, we can discuss the pitfall later on in the discussion. 1 minute to wrap up here. Actually, this is where we are with scoring guideline. Syntax score is in the class 1B, despite all the problem we have with that for complex CAD. And the syntax score 2 is a 2AB, and pending actually software and internet website to compute it. So in conclusion, I think risk score is great. It can help to guide treatment, including clinical variable help, but it's not perfect. I think we need to go for a personalized approach. For me, I think the computation of the score do one thing that is very good, is we start to think, and we discuss. And to do that in a heart team would be better, because we can really see talk with the surgeon what will be the best approach. And I think what will be the last frontier would be to do the functional syntax score 2, non-invasive, and be able to compute the residual functional syntax score 2, and so on. So I will conclude on that I believe that CAD assessment should be based on ischemic determinant first, more importantly, pre and post revasc. Something this is missing here is we assume that we did a good job, but we never test for ischemia after. We should aim for a reasonable ischemic revascularization, not damage the patient if you're not able to do it. And I think the dynamic of the heart team should be twice. First of all, adapt to your center and the expertise of your center. We don't have Stéphane Rinfret in every cath lab able to do every CTOs. And we don't have surgeon able to do full arterial revascularization in every OR. So I think the hybrid approach should be probably the one that should be favored. And I think I will end up on that. Thank you so much.
Thank you very much for the fascinating presentation. So